Assalamualaikum and good evening. Assalamualaikum and good evening to everyone. And we are here for the CBU of 19th of November. And today we are going to talk about role of contrast-enhanced ultrasound renal masses. My only disclosure is that I am a urologist and not a radiologist. So I'm very fortunate to have Dr. Basit Salam, who is a consultant radiologist in Sultan Qaboos University. Most of you know him very well. An ex-alumnus of graduate of and consultant at Ahan. So what we're going to talk about is role of contrast-enhanced ultrasound. I don't know about other places, but Pakistan is still far behind in that technology, and hope we will get some understanding of this. Please feel free to ask questions, and we in between, and Dr. Basit and myself will try to address these questions. So it's important to remember that patients with renal masses frequently require imaging, and that imaging essentially not only for diagnosis and but also for follow-up. We know patients with cancers require very frequent imaging. Use of contrast medium is essential in order to define these masses. And contrast is associated with significant morbidity. So people who have pre-existing renal functional impairment, patients with diabetic nephropathies, elderly individuals, those who have issues with perfusion and ischemia, are also at high risk. Hypertension, anemia, metabolic syndrome, so the risk factors for contrast-induced nephropathy. Now, why contrast-induced nephropathy occurs is something that we have a clear understanding of it, and I'm going to talk about it in the next couple of slides. So either it's direct nephrotoxicity of the contrast agent, it is due to the ischemia and hypoxia that it induces, the contrast agent, which results in ischemic injury of the renal parenchyma, the oxidative stress, initiation of inflammatory processes, apoptosis, and obviously we see that it is seen in some individuals and not in all. So some have epigenetic regulations of these phenomena, which can cause problems. So it's important that the use of contrast agent is appropriate. We have a significant hydration requirement in order to decrease the chances of contrast-induced nephropathy, and pharmacological prophylactic agents are given, and we'll talk about briefly about those agents as well, which can prevent the contrast-induced nephropathy. Now, this is a little pathophysiology of how it happens. So it's important to see that once the contrast agent is injected intravenously, it goes through the circulation into the kidney, and there it can have significant effects. So increasing viscosity of fluids in the vascular and tubules results either in direct toxicity, which is due to tubular epithelial necrosis, and these necrosed tubules can actually clog and causes tubular obstruction, which increases the tubular pressure and obviously impact the GFR. On the other hand, the contrast agent itself can result in endothelial dysfunction with release of nitrous oxide, the various response agents to inflammation, including ET1 and adenosine. And all this increase can result in vasoconstriction, microvascular thrombosis, medullary ischemia, and this can result in contrast-induced nephropathy. So it's a complex phenomena with interplay of various pathophysiological events which are taking place more or less simultaneously. Now, We know we need to take care of certain medications which can cause contrast-induced nephropathy. We need to take care of the fluid and hydration status. There are some agents like the N-acetylcysteine, which I personally use quite frequently in patients who are at risk of developing contrast-induced nephropathy, although the evidence is mixed. And this is a Journal of American Medical Association meta-analysis and a systematic review published a few years back, in which the findings are overall mixed. However, in over 100 randomized controlled trial, N-acetylcysteine was associated with prevention of contrast-induced acute kidney injury. And if you look at all these studies, generally that's the consensus of these studies. So this is something that can be used with some element of evidence now available. So patients with kidney masses are themselves at risk of development of renal dysfunction. So if you look at this graph, you can see that patients who had a partial nephrectomy versus non-cancer patient, or patients who have a radical nephrectomy versus non-cancer patient, there is significant hazard of developing renal dysfunction. So the kidney cancer itself, besides all the other factors that we have talked about, contrast, and are at risk of end-stage renal disease and CKD. So this is an important consideration, and we need to remember this. This is a paper published about 5 years back, and as you can see, that renal mass in malignancy-induced end-stage renal disease is significantly more than patients, controlled patients who have benign kidney tumors or who have traumatic surgical loss from surgery, from benign diseases or trauma, etc. So in these three groups, the end-stage renal disease development in patients with renal masses is significantly more. Now, let's come to the discussion point of this evening, which is the role of the contrast-enhanced ultrasound. Now, consider a picture in which there is an incidental diagnosis of a renal mass. If it is a pure cystic mass on a grayscale ultrasound with through transmission, we know that this is a pure cystic or Bosnia 1 lesion, and it can easily be, you can reassure your patient and you don't want to do anything further. However, if you have a complex cystic mass, you probably need better definition using multiphase imaging, such as CT scan or an MRI scan. If you have tumors, or if you have a 2F lesion or a 3 lesion, which is not treated surgically, you probably would require follow-up imaging. And all this can potentially increase the chances of, contrast-induced nephropathy. So is ultrasound, using an ultrasound contrast agent, has any indication in this regard? So the data is quite clear, and it is being around for quite some time, that contrast-enhanced ultrasound is more sensitive in certain situations than even contrast CT or an MRI scan. The difference between a CT and an MRI scan is that ultrasound can detect subtle perfusion abnormalities, which can be missed even on a CT scan. The advantage is it's relatively inexpensive, and it can be performed quickly without any preliminary laboratory testing. So obviously, You don't need to have a normal functioning kidneys in order to do contrast-enhanced ultrasound. So a little bit about mechanism here. The contrast-enhanced ultrasound relies on the use of an intravenous injectable agent, which is a microbubble encapsulated in a matrix shell. These are smaller than the red blood corpuscles. The microbubble demonstrates non-linear oscillation between 3 and 5 megahertz. This is what you can pick up using your regular high-frequency probes. After certain circulation, certain cycles of circulation in the system, these microbubbles dissolve. The internal gas is exhaled, whereas the coating, which may be of proteins or polymers, is metabolized by the liver. So essentially, there is no renal excretion of this contrast agent. So microbubbles are exhaled through lungs, and the polymer coating is metabolized by the liver. So there is no direct impact on the kidney. Now, in order to detect microvasculature, we know that Doppler ultrasound can image blood vessels which are as small as 100 microns, whereas a contrast-enhanced ultrasound can see or show or demonstrate vessels nearly half as small as what can be seen on a Doppler ultrasound. So even 40 microns are visible, excuse me. It has a high temporal resolution, and it provides a continuous dynamic imaging in contrast to static acquisitions which are seen in MR or a CT scan. The contrast agent passes through the renal artery into the main branches first, followed by segmental, interlobar, arcuate, interlobular arteries. The complete cortical enhancement is seen in between 15 and 30 seconds of injection of the contrast agent, and this is what results in the nephrographic phase. The medullary enhancement, which follows and is seen between 25 seconds to about 4 minutes. And since it is not excreted by the kidneys, so there is no delayed or excretory phase which is seen. So I'll stop here, and a few words from Dr. Basit on the technical issues that I have talked about, and then we'll proceed. Basit, would you like to add something to this?
No, I think you have described everything perfectly, and this has been some recent gaining interest of the use of contrast-enhanced ultrasound for detection of the renal masses, which helps in characterization, and it has been observed that the contrast-enhanced ultrasound, as you have already described, can be seen in 40 microns, and the best thing is that it has a sensitivity that is so far it is very promising, and but the only limitation is that the field of view is a focused area, so we cannot use that for the purpose of staging, which is one important requirement whenever we are looking at the tumors. So rest you have described very well, I think.
Okay. Thank you, Dr. Basit. So let's move on. Now, I'll give you some examples, and we'll try and see, and we'll have input from Dr. Basit Salam as well on in which situation contrast-enhanced ultrasound can be of help. So consider an incidental finding on an ultrasound of an avascular mass which is on conventional Doppler ultrasound, there is no flow. However, it doesn't meet the exact criteria for a simple cyst. So that's one situation. Another situation is that there is a solid mass which mimics a tumor, but it could well be some of the what we call as pseudolesions or pseudotumors. The third situation is that we have a complex renal cyst, which should be characterized as a benign cyst or a malignant cyst, because if it's a benign cyst like a 2 or 2F cyst, it requires follow-up or reassurance. If it is 3, which is very highly suggestive of a malignancy, or 4, which is definitely a malignancy, it should be characterized as a surgical cyst and require some form of a surgical management. So that is the thin line is sometimes there, and we are not able to characterize even on CT and MR the complex renal mass as this or that. Then we have renal lesions, which are identified as ill-defined on CT scan, or they are equivocal enhancement on CT scan, which is not clearly suggestive of a malignancy. The fifth scenario is that you have treated a kidney mass with, say, focal treatment like HIFU or RFA is more frequently done, or cryoablation, and you want to a microwave thermotherapy, and you want to look at the success of this lesion for which you require a follow-up scan. So all these situations, ultrasound, contrast-enhanced ultrasound has some indications. Now, this is a 50-year-old male, and this is what you can see. Is my arrow visible?
Yes, yes.
Okay. So this is non-contrast or pre-contrast MR, and you can see a lesion here, in a small lesion in the periphery of this lower pole outer border of the kidney. The post-contrast corticomedullary phase PET suppressed T1 weighted image essentially shows that the lesion have enhancement, but it's not very definitive. So about less than 13% enhancement, and we know that under 20% is probably in the gray area. So even with this picture, we are not absolutely sure if this lesion is solid, which is suggestive of a tumor, or we are dealing with a lesion which is more benign or cystic, like we have very clear cystic lesions elsewhere in the kidney. A contrast-enhanced ultrasound, on the other hand, clearly shows contrast enhancement, which is different from the parenchyma, which is significantly more than the normal cortex. And this is quite clearly suggestive of that this lesion is malignant. Subsequent, in this case, pathology was done, a biopsy was performed and followed by treatment with radiofrequency ablation. And this is something which proved to be a clear cell carcinoma. And any finer points, Basit, before I proceed to the next case?
No, you can continue.
Good. So feel free to please stop me and add anything if I'm technically incorrect in pointing out in these sophisticated scans. So the second indication or scenario is differentiation between solid and cystic lesion. So the sensitivity of contrast-enhanced ultrasound is more to detect even minimum blood flow. As we say that you can detect microvasculature of even 40 microns. So it can actually, and it doesn't give you the static picture that we have on CT and MR. What we are seeing is a real-time imaging. It is highly effective to differentiate tumors from cysts containing blood or debris. So it is not very unusual for clinicians to see a patient with a history of multiple cysts in the kidney or cyst in the kidney in which there is bleeding. And now your CT or MR would show some element of hyperdense or shadows in that lesion, which could be suspicious of cancer, something that we can differentiate using contrast-enhanced ultrasound. The solid tumors are hypovascular, but they enhanced on contrast-enhanced ultrasound. Tumors which do not enhance on CEUS are definitely benign cysts, and they can be easily followed, or patients can be reassured that it doesn't require any further. The one more clinical area that we often as clinicians find issues is that patients with end-stage renal disease or CKD who have complex benign cysts, and they are very frequently seen in patients who are on dialysis, and they have these complex lesions. Contrast agent administration is difficult, so ultrasound definitely had a role in this. Now, if you look at this scan, you can see a lesion which has the same appearance as that of the closed birenal parenchyma, and this lesion, as the arrow suggests, is exophytic. So this is really suspicious. If you do a contrast-enhanced ultrasound, it clearly shows that this is absolute no enhancement in this lesion, and this can be purely regarded as benign. This is a patient with polycystic kidney disease and end-stage renal disease. You can see multiple cysts in this T2 weighted images. And however, there is one lesion which is complex. However, this MR is not able to define what this lesion is, but it definitely raises significant concern about this lesion, and it requires further elucidation. If you look at the ultrasound here, this ultrasound shows that this is irregular. It has thick septa. And again, according to this ultrasound, it definitely seems to be a highly suspicious lesion. Whereas and again, this is a grayscale, this is a contrast-enhanced ultrasound. And quite clearly, there is no enhancement in this lesion. If you have blood and debris, it would not enhance. If you have a vascular structure, a nodule, or a septa thick with some micro circulation, this would enhance on an ultrasound, whereas an MR, a good quality ultrasound, is unable to define this lesion. A contrast-enhanced ultrasound really clarifies the situation. That's what we see inside this cystic mass is basically blood and not a nodule or a tumor. Basit, would like to add anything?
Yeah, Dr. Hammad, yes, you are absolutely right. If we only go for the grayscale assessment and MR, we will definitely label this as something which is complex and need to be further evaluated based on these, because differentiating this from a solid mural nodule versus blood on the otherwise grayscale and MR in isolation is really difficult, and contrast-enhanced definitely helps.
Okay, thank you.
Yes, sir.
So clearly see that the contrast-enhanced ultrasound is at times clarify situation where CT and MR cannot. Now, it is helpful in complex cystic masses as well. The contrast-enhanced ultrasound is superior because it can pick up minimum enhancement, of septa, cystic wall, and if there are any solid components in a cyst. It can provide you for follow-up of non-surgical lesions as well. So then you obviate the need of giving IV contrast. So when you follow these up, the additional advantage of a contrast-enhanced ultrasound is that it will pick up fine changes within that complex cystic mass. So if the septa has thickened, or if the nodule has increased in size, or its vascularity has, all these indications that there is some changes which is towards malignancy. Obviously, this comes with the benefits of reduced cost, but there are certain limitations. So you can see in this lesion where there is an asterisk that there is a septa and a calcified thing within this lesion. If we look at the contrast-enhanced ultrasound, it doesn't seem to show clearly if there is any enhancement. And the reason is that there is acoustic shadowing at this point. And this shadowing from either bowel gas or ribs or patient's constitutional, the body habitus, or wall calcification, casting shadow is one of the limitation of the contrast-enhanced ultrasound. And this thing is clarified now in this MR image that this is likely to be a cystic mass rather than anything which is. So Basit, can you just explain a little further about one of this limitation, which is, I think, a generic limitation to ultrasound, but is also seen in contrast-enhanced ultrasound?
Yes, as you said, because of these dense calcification, this actually hampers the transmission of ultrasound waves because they get reflected. So sometimes it is challenging to see behind these areas, and we then need to like see the other available imaging, like in this case we have the MRI, so you have to compare these things together. And one just limitation for most of the ultrasound examination is the operator who's performing the ultrasound, because ultrasound is one modality which is very operator dependent.
Yeah, that's true. I think that's globally for all kind of ultrasound, and obviously this is something that you need to be. Can you explain why CUS is probably more dependent upon a person's ability to do ultrasound? Because these are subtle changes which appear and can disappear quickly as well, depending upon which nephrographic or corticomedullary phase you are. And you have to appreciate these changes in a short window frame. So can you say a few words about this particular technical difficulty?
Yes, yeah. Yes, as you have already been describing these in your previous slides. Kidney is one organ which moves with respiration, and while doing ultrasound, the window is like limited if we are focusing on the kidney. So kidney as such is focused, but if with the patient's respiratory movement, the area, if it is really small, like we are seeing in few of the cases that you have just shown, making that that area focused in the center of the screen is sometimes challenging and requires a lot of cooperation from the patient. Because this thing is time bound, we have to see the cortical and the medullary phase in terms of the time, because it takes like the time that you have already described, 15 seconds to like 40 seconds between these two phases. So where one has to be like very experienced and should have very stable hands to do the ultrasound and simultaneously. And it is like something which is very important to record the images in a cine mode so that you can see the changes that are happening, because these are all micro bubbles. They the ultrasound or the nano bubbles, so they give you the enhancement kind of pattern that we see in cross-sectional imaging. So this is something which is required for this dedicated ultrasound, and of course, experienced person will be able to appreciate these subtle changes better.
Thank you. So another important area that we have initially talked about in which contrast-enhanced ultrasound can be of help is differentiation of a solid lesion, which looks suspicious on an ultrasound or at times even CT scan or MRI scan, is a pseudolesion. So pseudotumors like prominent column of Burton, persistent fetal lobulation or domed hairy humps, cortical hypertrophy in areas which have cortical scarring. So all these things are benign or normal variation of anatomy. However, on imaging, they can be quite confusing. So conventional ultrasound essentially identifies medullary pyramid within the pseudolesion, and that's obviously indicative of that it's a pseudolesion rather than a cancer. Doppler ultrasound is also helpful because the vascular pattern of the parenchyma, normal parenchyma, and that lesion can be. But contrast-enhanced ultrasound essentially extremely useful because it can show various vascular phases of normal parenchyma versus the pseudolesion, and you can actually make a clear differentiation between a pseudolesion and a tumor. So as an example, if you look at this image, you can clearly see that on an ultrasound, we are seeing a large lesion related to the kidney, the left upper pole of the left kidney. And this is very suspicious on this ultrasound. And we really need to see if this solid lesion, which has more or less the same density, same echogenicity of that of the parenchyma, is really something which is a tumor or it is something else. So if you do a contrast-enhanced ultrasound, you can see that the contrast enhancement pattern of this lesion, which is seen here, is not very different from the rest of the parenchyma. However, and this is something which is indicative of this as a normal variation of anatomy rather than a tumor. However, if you look at this medullary phase, you can actually identify a medulla within this lesion, and it is actually the presence of this medulla is quite diagnostic in differentiating a tumor versus a pseudolesion. Basit, any fine points, anything that you would like to add?
Yeah, I totally agree with, and very well defined.
So another example of the same, the first picture is showing a grayscale ultrasound with focal thickening of the mid portion, which is shown by the asterisk, which is isoechoic renal tumor. Now, color Doppler ultrasound can actually further classify this thing as something suspicious, or is it a normal variation? The contrast-enhanced ultrasound during the cortical phase is showing enhancement of the cortical portion where there was cortical thickening. The medullary portion shows delayed enhancement which is shown by the curved arrow. Now, the CUS during the parenchymal phase shows progressive enhancement of the medullary portion. So now, looking at these three phases, the grayscale ultrasound versus the early phase contrast-enhanced ultrasound, and then the medullary phase, can actually very clearly differentiate between pseudotumors and these solid renal masses. Another area which is important is the characterization of complex cystic masses. And we need to assign a Bosniak classification or a grade in order to define which tumor requires follow-up, which tumors require surgical treatment, which can be clearly designated as a benign lesion and can be easily, the patient can be easily reassured. So if you look at figure A, there is a 2F cyst, which is a benign cyst. Imaging surveillance is advised in this situation because of the very subtle enhancing irregularity in the wall. The irregularity disappeared during the follow-up. Category 3 cyst of, and I'll talk about it a little further subsequently, that the classically described Bosnia classification was for CT scan, but now we have Bosniak for the ultrasound as well. So the category 3 lesion, which is sort of indeterminate lesion, which cannot be 100% benign or malignant, but it has multiple septa, which are enhancing. There is irregularity. And in this situation, the histopathology revealed a multicystic nephroma in this patient. Whereas if you look at this example C, with the asterisks indicating intraregional enhancement in this area, which it was defined to be a papillary renal cell carcinoma. So Bosnia classification, again, we now know that it can be and should be used for ultrasound as well, because we can see all those things which we can define in a CT scan. So we can see the cyst, we can see septa, we can see intralesional nodules and their enhancement pattern. So there is no reason why Bosnia cannot be used for ultrasound. Now, contrast enhancement showing indeterminate left renal cyst, and I'll show you the pictures. This is a lesion. If you look at closely, they are very fine septa with indeterminate or subtle enhancement. This is a part endophytic and mostly exophytic mass lesion arising from the left kidney, and it was categorized as Bosniak 3. The contrast enhancement ultrasound essentially showed obvious enhancement of the wall and septa, as you can see with the arrows. The histology revealed that it is a multilocular cystic renal cell carcinoma. An example of a 62-year-old male who has an incidental finding of a right renal mass. This is a grayscale ultrasound, which is showing a heterogeneous, partially exophytic lesion at the lower pole of the right kidney. The corticomedullary phase contrast-enhanced ultrasound show avid enhancement, which is shown here. And then there is a necrotic center, which is here. The normal renal cortex, which enhances less avidly than the peripheral lesion. So These are very subtle differences, and this is what Dr. Basit was talking about earlier, that you need to be really extremely good and look at this subtle difference between and I'll seek his opinion shortly on this as well, that what are these subtle differences between the normal renal cortex and that of the tumor. So narrow window settings of the contrast enhanced ultrasound, again, more clearly identified that there is intensely enhancing lesion here, which is definitely confirms the presence of a lesion, which is suspicious. So washout of the mass compared to the normal adjacent renal cortex, again, is an indicative of a carcinoma rather than a benign lesion. So you can see that these are very subtle changes which has to be appreciated. And if you're really good with this tool, you can really make very quick diagnosis on even patient's bedside using this technology. Basit, any words on this case?
I think very well defined, and I totally agree with this. It is the differential. We use these terms attenuation in the appearance, or the different attenuation in different phases of the study that makes the lesion which we are suspecting more stronger to be a real lesion versus a pseudo lesion.
So can you say a few words about the time intensity curves and its value in this contrast enhanced ultrasound?
Actually, this is just like we need to, like you have described, the phases that we expect after injection of these contrast. So we have to see the different attenuation of the lesion versus the normal renal parenchyma, and the uptake of the contrast in the lesion versus the rest of the normal renal parenchyma, and we compare that because there is like new vascularization and hypervascularity in these lesions. So we expect the contrast uptake in the lesion to be more versus the normal renal parenchyma, and in like delayed phases, which is near where we expect to see the excretory phase in cross-sectional imaging, which is not the case in ultrasound contrast. So we see that the contrast has gone through the lesion versus it is still present in the normal renal parenchyma.
So the washout of a tumor is more rapid than that of the renal parenchyma. Is that?
Yes. That is some feature which makes it like a confirmation of the abnormality that we are suspecting to be a real abnormality, and making it more being a possibility of a tumor.
Thank you. Okay, so another example, you can easily see a complex cystic mass here on an ultrasound. Again, if you look at the contrast enhanced ultrasound, clearly it is showing an anechoic lesion, which is something that you can reassure the patient. So you don't really need to do anything further. Now, this is an interesting case. And if you look at there are certain things that we need to know before we move on to the images, that the renal masses with the density on unenhanced CT scan, and that's what we do very commonly in our clinical practice for a stone and obstruction, is that if you have a lesion which is less than 20 ounce field unit, or if a lesion is greater than 70 ounce field unit, they are really benign. So it is the 21 to 69 is the real gray area or indeterminate area that sometimes require, because you see these parenchymal lesions on non-contrast CT, which are suspicious. And often I disturb our radiologists that what do they think this is? And obviously in some situation, they're quite sure that this is not a tumor based because it is less than 20 HU or greater than 70 HU. But if it is in between that range, you really need to further define this. So in this case, you have a lesion which is 39 Hounsfield unit. So this is a gray area. Following contrast, the increase in the enhancement was about 11. And again, another important area that if you see that this is non-contrast 39 Hounsfield unit, post-contrast 50 Hounsfield unit, the increase in the density after the injection of contrast, if it is between 10 and 20, and in this case it is 11, then again, it's a hypovascular tumor or a cyst or a pseudotumor. However, so from this picture to this picture, meaning non-contrast CT to a contrast-enhanced CT, we still are not sure, and this is still an indeterminate mass until we do a contrast-enhanced ultrasound, and in which you can clearly see that there are 3 separate lesions which are contrast-enhanced, and they are highly suspicious of a tumor. Any word on this, Basit?
No, I think you have described it well here.
Right. So let's take 1 or 2 more cases, and I think we can wrap it up. Again, very similar to what I've just described in the previous case, a 67-year-old male with an unenhanced CT scan, which has shown a clear, well-circumscribed, solid lesion on unenhanced CT. This is your contrast-enhanced CT, which shows just about 5 centimeter tumor with peripheral focal wall thickening, as is indicated by this circle, that there is some thickening at the junction of the normal parenchyma and the mass lesion. However, it is less than 20 Hounsfield unit, which indicate that this is a likely to be a benign lesion which requires follow-up. This same patient with a subtraction post-contrast fat-suppressed T1 weighted coronal MR image during the corticomedullary phase. And again, it shows there is no enhancing component in the cyst. So, so far, based upon the 3 examination, uncontrast, non-contrast CT, contrast CT, and corticomedullary phase T1 weighted image on MR is indicative of a benign lesion. Would you agree with the Basit in what is shown so far is something that you would be happy to characterize as a benign lesion?
Yes, if I have been given these cross-sectional imaging, so I will label this lesion as benign because it is not fulfilling the criteria as per the current renal mass evaluation to be of any suspicious lesion, and we will definitely label this as Bosnia 2.
Yeah. This is the contrast-enhanced ultrasound, and this is in comparison the grayscale ultrasound of the same. And you can see that this very fine enhancement that we were seeing on the contrast CT is actually quite prominent here. And this definitely fulfills the criteria. And now would you be satisfied to call it a RCC?
Yes, definitely. This enhancement is very suspicious. It is nodular. And if you compare even on CT and MR, the appearance of this is like misleading, that to be of a benign cyst, and based on this contrast enhanced ultrasound, one would definitely call this to be highly suspicious enhancement, making this most likely category 4 Bosniak cyst. And that is the beauty that is being claimed for contrast enhanced ultrasound, that it picks these subtle vascularity within the lesion more precisely with greater sensitivity.
Yeah. So I think for the sake of time, I'll skip this. This is the Bosnia Classification, and it's all available. This is the proposed contrast enhanced ultrasound Bosniak classification, which mirrors very close to the classification that we have. But here you can see that they are quite clearly defined objective parameters, like the thickening of the septa, the size which you can measure, how many septas that you have, and based upon all this in the enhancement pattern, you can actually categorize these lesions into a Bosniak 1 to 4 lesions, and definitely this is quite helpful. So let's move to this, I think, 1 or 2 last cases, and then we can wrap up and take your questions. So in this, the cystic complex cystic mass identified to be a 2F cyst on initial CT scan. This is the non-contrast CT. This is contrast-enhanced CT on the arterial and the venous phases. And you can see that there is very subtle enhancement in certain areas with the very fine enhancement pattern, which is probably giving it a little suspicion that it should be followed up rather than definitely characterized as RCC. Whereas on a grayscale ultrasound, again, this is much better seen than even on a contrast CT. So here you can see some element of calcification or hyperechoic areas, which are very suspicious in the cystic lesion. And if you do a contrast enhanced ultrasound, again, it is very clearly indicative of a solid nodule, significant size within this complex cystic mass. And this lesion was resected, and it was found to be a multilocular cystic renal neoplasm. Okay, so I think we can skip 1 or 2 examples. Another area which we as a clinician find a difficult domain is to identify a benign kidney tumor like an oncocytoma. And if you look at this, this looks quite typical with the typical central necrosis with the stellate scar, not clearly stellate scar in this one, but this sort of spoke wheel pattern in this lesion. But this can well be RCC, because we know that RCC can present in various shapes and sizes. So it's really very difficult to categorize. So oncocytoma, there's always a clinical dilemma that is this, we have very little certainty on identifying it as a oncocytoma on CT and MR at times. Even pathology is difficult because we know that low-grade chromophobe RCC appears very similar to an oncocytoma to a pathologist. However, on the ultrasound, we know that it filled from periphery to center during the cortical phase. It is hyper-enhanced related to the normal renal parenchyma. hyper enhancement persists through the corticomedullary phase. And so this is something that is probably helpful, but I'm not really sure how effective this is in identifying. Data is also not very clear about if your oncocytomas can be diagnosed definitively with the contrast-enhanced ultrasound. So for small renal masses, this is an algorithm. If you do, if there is a contraindication to CT or MR, or if it is incompletely characterized on CT and MR with no gross fat, no definitive enhancement, or less than 20 Hounsfield unit enhancement, then you can do a contrast-enhanced ultrasound. If it is showing no vascularity, there is no solid tumor, and you can be absolutely sure that there is nothing suspicious. If you have high vascularity, it is likely to be a solid tumor. If it enhance greater than the less than the cortex, it is mostly malignant, and you can avoid the biopsy and make a surgical decision about treatment. If it is enhancing greater than the cortex or equal to the cortex, it is sort of indeterminate mass, and sometimes biopsy is recommended. Would you agree with Basit? This is how would you make decisions?
Yes, definitely, definitely.
So, in summary, it is a problem-solving technique for characterization of renal lesions, which are indeterminate on imaging. It can differentiate between renal tumors and pseudolesions or anatomical variants like column of Burton. The characterization of complex renal cyst and indeterminate lesions can be helped by CEUS. The non-surgical lesions can be followed effectively without use of significant amount of contrast. There is no renal impairment using the microbubbles. They're quite safe compared to the iodinated contrast of CT or the gadolinium-based contrast agents used in MR. It can be done on bedsides. So thank you very much. And if there are any questions, myself and Dr. Basit. Basit, there's a question from Dr. Nazem about how sensitive it is for angiomyolipoma. And I think particularly he would be interested in knowing AML with little fat or no fat.
Yeah, I think those AMLs which are lipid poor or with poor fat, they are sometimes a diagnostic challenge for the radiologist as well, because differentiating them from renal tumor is difficult. And there can be RCCs which may have fat, but usually it is said that for CT, if there is absence of calcification or ossification that we see, then the diagnosis is more in favor of AML. And the incidence for this lipid poor angiomyolipomas is like around 5%. And the contrast-enhanced ultrasound may help, because these usually will show us enhancement at the periphery, and there is decreased central enhancement if we compare it with the normal cortex for angiomyolipomas when we are evaluating them on contrast-enhanced ultrasound. And of course, on grayscale appearance, these are usually cortical-based lesions, and they appear most of them appears relatively more echogenic versus the normal renal parenchyma.
There's a question from Arshad. He wants to know if the CT, contrast CT, has shown a Bosnia 2 lesion should we not do anything further? Or do we do a contrast-enhanced ultrasound?
Well, this is something which I will say depends on the clinical suspicion as well. If we are more suspicious, then we definitely have to have the second imaging, or if available, contrast enhanced ultrasound. But if the CT findings are very characteristic to be labeled as Bosnia 2, there is no septal thickening that is more than 4 millimeter, or there is no nodular thing that we can appreciate, so we can stop there. If we have all the features, like there's a checklist that you while reporting you see certain things. So if we are not able to see any indeterminate features, then we don't need to be worried up and moving further for further evaluation. But if there are some indeterminate things, like the density is in the indeterminate regions, there is questionable nodular thingy, then we have to further characterize that lesion.
Yeah, I think I agree that two are generally, if the CT is clearly indicating a Bosnia 2 lesion, we probably don't really need to do anything further. But if there is a clinical suspicion because of the history or some other associated findings, then definitely contrast-enhanced ultrasound probably will be modality to go. Professor Nasser Origzai has asked, how long do we need to follow a Bosniak 2F cyst? So perhaps it is for me to answer. The typical evolution of tumor is such that if you have a 2F cyst with very thin septa or very subtle enhancement, which is not in the suspicious range, and the difference in enhancement from non-contrast to contrast or change in the density is not significantly in the suspicious range, this patient would probably require a few imagings. And if there are no changes from the one that was originally done to at 6 months or at 1 year, then in that situation, you probably don't need to follow it any further. However, there is no clear answer in literature that how long should it be followed. In the small lesions are very likely to grow slowly, so you probably need to follow them for longer period. If there is a big lesion, then it is probably likely to grow quickly, and you can have changes observed within the first year. And if those changes are not coming in the first year, you probably don't need to do anything further. I hope, Dr. Nasser, if this is answer your questions.
Yes. First of all, I must say that it was very interesting, very enlightening modality, which is obviously not in practice here, if I'm correct. So that was very interesting. Just one question to Dr. Basit Salam. It's regarding patients who have got dysfunction. So what is that you consider more important? Is it just the creatinine or is it the EGFR?
Now, yes, thank you for this question. Now, it is the EGFR that is important. And most of the centers, the current practices, if the EGFR is greater than 65%, they allow the contrast to be administered. But there are new promising data that are coming through different RCTs, but it has not been approved for these patients, that if the EGFR is like between the range of 40 to 60, then still the contrast can be used. But it is now the EGFR, not the creatinine level, that we usually see before offering any contrast study to our patients.
Thank you. There's a question from our friend, Dr. Marco Reber from UAE. Good evening, Marco.
Hi.
Right. So he wishes to know that it is safe to do it in an office setting? Do you need anything? You need to be careful about anything? As far as I know, barring the current generation or the second generation, the contrast agent like Sonoview, they are quite safe and they do not require any further monitoring. Except that if you have an allergic reaction, you need to be careful. Basit would like to add something.
Yes, I agree. The second generation ultrasounds, they are much safer and they can be used because they do not require any prerequisite except for the allergic thingy. Otherwise, there is no prerequisite for administering these contrast. And if one have like this, if we can use it as point of care, so it can be used provided one has the expertise.
Yeah. I hope, Marco, this answers your question. I think
Yes, of course. Now, in terms of formal report, for example, if I send a patient nowadays, I send a patient to radiology department for this imaging. So I will get a formal report, but maybe the imaging is not so friendly. So I need to have a computer, CD-ROM to run the program, the software to see everything. So I have to, we are in the generation that we like to see as well the renal masses on our own. For example, a CT scan. After the urologist opinion, we like to, as a urologist, to see as well, to have a second look as well. So in this case, maybe we need to relay strictly to the word of formal report instead having an idea in a direct visual of the exam, of the imaging.
Yeah, I think this is absolutely correct, Marco, because really what happens is that even the grayscale ultrasound or the Doppler ultrasound pictures that you see is the one which the sonographer or a sonologist or a radiologist considered as important and relevant and takes an image, and this is what you see. So this is really a very static image of things. So you really need to rely on his or her word about what is the interpretation of that the radiologists have actually seen. So yes, you're absolutely right. I mean, it's very different from a CT or an MR that you see on a CD, and you can look at from various angles and reconstructions and so on. Same is not true for ultrasound. Basit, is that true?
Yeah, you are absolutely right. And this is one limitation, that the person who's performing the ultrasound can have everything that can be seen in real time versus on the static images that they provide. But now there is a changing practice, and now all of the ultrasound machines have a small capability of making a cine of the ultrasound examination. And most of the sonographers, they are like taught that if they see something which is difficult for them to be characterized, so they then send the cine of that particular, even for the grayscale assessment. So that makes the person who's interpreting the images a little easy job. But of course, the real time versus the static thing is some technical limitation of ultrasound. And these contrast enhanced ultrasound will will be offered as a static as well as with small cine like clips from the machine.
Yeah, so there's one more question coming from Nazim, and he likes to know if it can be combined with color Doppler. Yes, exactly. It can be combined with color Doppler. And as I've said, that the color Doppler can look at vessels which are 100 microns, whereas contrast-enhanced ultrasound can see vessels, microvasculature up to 40 microns. So definitely they can be. There's another hand raised by Richard. I think he dropped his hand.
Just was trying to make a comment. It's Munir Hammad.
Good evening.
I just really I just wanted to make a comment that
Yes.
it is we can do as surgeons a lot of imaging in the office, but this modality is really for solving difficult problems. So by definition, they are complex cases. Second bit was that a lot of contrast-enhanced ultrasound is based on studying vascularity and then interpretation in context of other imaging. So my thoughts are that it will be very difficult for a surgeon to engage in carrying out contrast-enhanced ultrasound in an office situation by himself, because that requires multiple heads. The final bit was that because it is a study of the vasculature and the vascular characteristics of the mass, then sometimes it requires more than one injection of the contrast. Sadiq can correct me if I'm wrong, but sometimes it may be up to 6, because I've seen it being used very extensively in the liver pathology. And in patients who have had transplants done for assessment of transplant dysfunction immediately after transplant. And all of this is really based on requiring more than one injection. So if you miss the vascular phase with the first one, then you can give another dose to look at it more carefully. So based on this, I think carrying it out in an office situation would probably be not meeting the normal criteria of decision making.
Please.
You're absolutely like Mr. Munir. This is true about contrast-enhanced ultrasound, that the windows are very, very fine. So we're talking about 15-20 second window for the nephrographic phase, and then 40 seconds, 25 to 40 second window period for the corticomedullary phase. Again, if you have obviously missed that, and this is and these are very fine and subtle changes that you need to observe. The pictures and the cases that we have shown are very classical things. Life is not that simple in a real life situation. It is much more complex. Basit, would you like to comment on Mr. Munir Ahmed's
Yes,
observations?
I think Mr. Munir have very well pointed out this, but the thing is that the thing that you have described, 6, 5 or more injections for the liver is true, but not for the kidney. You may require multiple injections, and that also depends on the expertise, because liver is a big organ. We cannot see liver even on grayscale by just keeping a probe on the right side. We have to see the segmental and respect the segmental anatomy of the liver. And that is how the person who's doing ultrasound is trained to take the images with respect to the distribution of hepatic veins and portal vein, so as to do the segmentation of these different segments of the liver. And of course, for that kind of work, we need multiple injections for the evaluation of liver. But of course, renal evaluation may require multiple injections, because we have to be focused at the upper pole or lower pole, or sometimes at the interpolar region. And of course, as I have previously mentioned, that we need to have the expertise for not only doing, but also reading the contrast-enhanced ultrasound. And this has to be complemented, as Nazim also ask one question about the color Doppler, it has to be complemented with the grayscale findings, with the Doppler findings, and the contrast enhanced. It is not an isolated test. Plus, of course, we have the cross-sectional imaging that we need to see, and everything that we are suspecting should be reproducible, which is making it definitive to be called as abnormal.
I mean, like everything else that we do in terms of the lab test or radiology, is that we have to go with a very specific question if you want to have a very specific answer. So I think the interaction between the clinician and the radiologist or histopathologist for that matter is extremely important, because as a clinician, you need to know what specific questions are you asking for the radiologist to specifically answer that question. So that communication is extremely important. And same as for pathology interpretation, that at times you have all that clinical information about the patient, and that make pathologist's job much easier. Nazim has asked about untoward side effects, rare side effects of microbubbles. I think with the new generation, and Basit can correct me, the new generation, the second generation contrast agent are quite safe. And the first generation was actually can only be used for heart because they would stuck at the lung level. But the second generation can pass through, and you can see the whole circulatory system because they can easily go into the kidney and liver, and you can see these. So as far as I know, none, but Basit can add.
Yes. So far it is none. But this is something which is ongoing, like any drug. But so far there are no reported serious side effects, except for minor allergy thingy. And this is like metabolized towards the liver. The kidney has nothing to do with this excretion or anything.
Okay, great. So I think we had a very, very fruitful discussion. I'm really grateful for all the audience and their very pertinent questions to Marco, Mr. Munir Ahmed, Nazim. They've asked some and made some very good observation. So thank you very much, and have a very good evening and a weekend. The first Saturday of December, we are going to have a session on minimally invasive surgical technologies for BPH, and it will be by Ananda Kumar Dhanasekharan from UK, 8 p.m. on, I think it is 3rd December. Sharif, is it 3rd December? First Saturday of 2000 of this year.
And
Okay.
I have a question regarding that. Can
Yes.
radiologists do something minimally invasive?
Well, you can do injections into the embolization is your domain, sir. We don't want to do it. Then there is ethanol.
Ablations.
Ablations are there. So they are some of the minimally invasive radiological interventions.
Yes.
Nobody is out of job here as far as BPH is concerned. So, thank you very much. And I'm grateful to my co-host, Dr. Basit Salam, for his very insightful comments. And to all the audience, have a very good evening. Assalamu alaikum.
Alaikum salam. Bye.
Bye.
Thank you. Bye-bye.